Lifesaver. This module is on cardiac arrest, your second module for the Advanced Cardiac Life Support Training course of the Philippine Heart Association. You have just come from the module on arrhythmia recognition, and by now, you must not find it difficult to identify the cardiac arrest rhythms. At the end of this module, you should be able to recognize cardiac or pulses arrest rhythms and manage these rhythms. This is going to be the outline of our discussion. Sudden cardiac arrest is an abrupt cessation of cardiac mechanical function, which may be reversible by a prompt intervention, but will lead to death if left unattended. It can occur as the heart's electrical system goes haywire, and the heart suddenly stops contracting and pumping blood. It can strike suddenly anytime, anywhere, and anyone, even individuals who seem to be healthy. Sudden cardiac arrest does not only mean a damaged heart. Other vital organs of the body are likewise compromised. When the heart stops to pump blood, the unperfused brain may suffer irreversible damage or death in just 4 to 6 minutes. Only 1 survive out of 10 who are stricken with sudden cardiac arrest. But if a bystander can give CPR and use an AED immediately, 4 more people could survive. 7 in 10 sudden cardiac arrest events happen at home. If a rescuer or a lifesaver like you gets delayed in responding immediately, the outcomes become worse with each second that you do nothing. Every second counts. Sudden cardiac arrest leads to death in minutes if a victim does not get help right away. For every minute that passes, survival odds decrease by 10%. A big question is, who will and won't survive sudden cardiac arrest? The initial rhythm that presents during sudden cardiac arrest may predict the outcome of a victim. Victims in a systole have 10% chance of survival until admission, but only less than 5% survive up to discharge. If a victim initially presents with pulseless electrical activity, the chance of survival up to admission is 23%, but only 11% survive until hospital discharge. Ventricular fibrillation portends a better prognosis at 25 to 40% chance of survival until hospital discharge, and hemodynamically unstable VTAC has 65 to 70% chance survival until hospital discharge. Sudden cardiac arrest due to non-cardiac causes has a 40% successful rate of resuscitation. 11% may get discharged alive from the hospital, and 6% are neurologically intact or would have mild disability. I will now walk you through the cardiac arrest rhythms. Let us briefly review what you have learned from the previous module. There are 4 rhythms associated with cardiac arrest. Ventricular fibrillation is a heart rhythm abnormality that occurs with the heart beating so rapidly due to erratic electrical impulses. Because it beats too fast, the heart practically quivers uselessly, and because of that, the heart fails to pump blood out of the ventricles. Pulseless ventricular tachycardia is another life-threatening cardiac arrhythmia, in which ventricular contractions are very rapid, but because of the speed, contractions are ineffective to pump blood out of the heart chambers. This leads to insufficient organ perfusion and heart failure. Asystole reflects the absence of ventricular contractions. Pulseless electrical activity refers to cardiac arrest rhythms in which the electrocardiogram shows a heart rhythm, but one that is not associated with the pulse. Thus, the heart ceases or is ineffective in pumping blood to the periphery. Let me take you now to the principles of managing cardiac arrest rhythms. We emphasize the term excellent CPR because anything short of this standard does not achieve adequate cerebral and coronary perfusion. A patient's chances for neurologically intact survival thus become compromised. When giving CPR, push hard. Chest compressions must be sufficient in depth and rate. Complete chest recoil must be allowed between compressions to be effective. Minimize interruptions. Current ACLS guidelines strongly recommend that chest compressions must not be interrupted. Other less vital interventions like endotracheal intubation or administration of medications to treat arrhythmias should be carried out while CPR is performed. But if an intervention has to be done, this can be carried out briefly during the rhythm check after a 2-minute chest compression. Quality CPR means avoiding excessive ventilation and rotating chest compressor. If no advanced airway is in place, a 30:2 compression-ventilation ratio should be carried out. The second principle is correct rhythm interpretation and management. You must correctly interpret or identify the rhythm on the ECG tracing or cardiac monitor for you to have the right management. Defibrillation is still the best treatment for ventricular fibrillation and pulsus ventricular tachycardia. The last principle is team management. Two principles provide the foundation for team management: leadership and communication. It is imperative that one person assumes the role of a team leader, and communication is organized to provide effective and efficient care. All the pertinent communication goes through the team leader, and the team leader shares important information with the team. The team is composed of the team captain, the airway manager, the chest compressor, the medication nurse, the electrical therapist, and the scribe. Each member of the code team has a specific role to play. It is through the full cooperation and integration of these roles that a code either runs smoothly or is disorganized and becomes chaotic. Ideally, a STEPS tool should be positioned at the side of the chest compressor, a backboard beneath the patient, and a defibrillator beside the electrical therapist. The airway manager is positioned at the head of the patient, the chest compressor positioned at the right side of the patient, the electrical therapist at the left side of the patient, the captain by the feet of the patient, the medication nurse by the left lower extremity of the patient, and the scribe by the right lower extremity of the patient. The captain should clearly identify himself and communicate with the team members. He may directly assign specific tasks to team members, directs the overall resuscitative effort, ensures optimal airway management, and issues all medical and resuscitative efforts. The medication nurse provides the vascular access, making sure that IV lines are patent for administering medications. The nurse also prepares and gives medications ordered by the team leader, and communicates data and complete interventions to the scribe and team captain. The electrical therapist operates and monitors the defibrillator. The airway manager ensures a patent airway as directed by the code team leader. He does the bag mask ventilation, prepares or assists with intubation, confirms ET tube placement, secures the ET tube, and accompanies the patient to any scans or tests to manage the airway. The chest compressor is responsible for performing chest compressions. This can be anyone with basic life support training and usually consists of two people who switch roles when one gets tired. This is to ensure quality chest compressions. Duties of the compressor include performing chest compressions of adequate depth and rate and allowing adequate chest recoil. The scribe communicates with the team captain throughout the code regarding which interventions have been given. He maintains an accurate written record of the timing of all interventions, including medications and electrical therapies. For this responsibility, he must have a working knowledge of standard ACLS. After the code, he finishes and submits a code sheet. At this point, you are now ready to learn how to manage cardiac or pulsus arrest rhythms. This is the most recent adult cardiac arrest rhythm algorithm formulated by the ILCOR, and I will present this to you one by one. These are the steps in advanced cardiac life support when managing an adult cardiac arrest patient. With ongoing basic life support, Hook the patient to a cardiac monitor and check the rhythm. After this, assess if the victim has a pulse or not. If the victim has a pulse, your patient is not in cardiac arrest and proceed either to bradycardia, tachycardia, or post-cardiac arrest algorithm as appropriate. If the victim does not have a pulse, identify if the rhythm is shockable or not. Proceed with the appropriate intervention, either defibrillation or chest compressions or medications. And once the intervention has been completely given, recheck the rhythm and repeat the cycle as necessary. While attending to a patient in cardiac arrest, bear in mind to simultaneously check for underlying causes while administering emergency interventions. Check for the 5 H's such as hypoxia, hypovolemia, hydrogen ion or acidosis, hypo or hyperkalemia, and hypothermia. Also check for the 5 T's such as toxins, tamponade, tension pneumothorax, and thrombosis, either a pulmonary embolism or acute coronary syndrome. Let me now present to you the specific interventions. We start off with the interventions for shockable arrest rhythms. The interventions for shockable arrest rhythms depend on how many defibrillation shocks you have already given. Do not worry. We'll break it down to make it easier for you to remember. Rule number 1. The priority intervention for shockable arrest rhythms is defibrillation. However, in case the defibrillator is not yet available for use, perform CPR first while someone else prepares the defibrillator. Rule number 2. After defibrillation, always perform CPR for 2 minutes and do not make the mistake of checking on the rhythm just yet. Rule number 3. Give epinephrine after the second defibrillation and every 3 to 5 minutes thereafter until resuscitation is terminated. Take note that epinephrine can be given even during CPR. And lastly, rule number 4. Give amiodarone or lidocaine after the third and fourth defibrillations. And just like epinephrine, amiodarone or lidocaine can be given even during CPR. If the patient needs another shock, then you have no choice but to give another round of defibrillation, and epinephrine can be given each time. Remember that epinephrine has no maximum dose and can be given every 3 to 5 minutes during a cardiac arrest. And that completes the array of interventions for shockable arrest rhythms. Now let's review. On the first shockable arrest rhythm, the interventions are defibrillation, followed by CPR for 2 minutes. On the second shockable arrest rhythm, the interventions are defibrillation, followed by CPR for 2 minutes, then administer epinephrine. At this point, consider placement of an advanced airway on the patient if not yet in place. On the third shockable arrest rhythm, the interventions are defibrillation, followed by CPR for 2 minutes, and the first dose of amiodarone or lidocaine. On the fourth shockable arrest rhythm, the interventions are defibrillation, followed by CPR for 2 minutes, and the second dose of amiodarone or lidocaine. On the fifth shockable arrest rhythm and thereafter, the interventions are defibrillation, followed by CPR for 2 minutes, and continue epinephrine doses every 3 to 5 minutes as it is necessary. Remember to do CPR for 2 minutes after each time you defibrillate, and epinephrine can be given every 3 to 5 minutes during shockable cardiac arrest. Moving on to the interventions for non-shockable arrest rhythms. Interventions are much simpler. These include CPR for 2 minutes and epinephrine doses that can be given every 3 to 5 minutes. Establish an advanced airway if not yet done. Let's now try to use the algorithm. Let's use an imaginary case. An adult cardiac arrest victim arrives and BLS is instituted. The victim is now hooked to the cardiac monitor. What should you do next? You should start by checking the rhythm. Upon checking, the first rhythm you see is ventricular tachycardia. What should you do next? You should now check for a pulse. If there's no pulse, what should you do next? You should identify if the rhythm is shockable or not. What do you think? Is the rhythm shockable or not? The rhythm is shockable. What should you do next? Perform the appropriate interventions. Remember from previous slides that the interventions for the first shockable arrest rhythm are defibrillation and followed by CPR for 2 minutes. What should you do next? You should reassess the rhythm. This time, the rhythm is ventricular fibrillation. Normally, you would check for a pulse, and if there is none, you will identify if the rhythm is shockable or not. But since ventricular fibrillation always presents as pulseless, you no longer need to perform a pulse check if the arrest rhythm is ventricular fibrillation. The same is true for asystole. Next, identify if the rhythm is shockable or not, and proceed with the appropriate intervention. Again, recall from previous slides that interventions for the second shockable arrest rhythm are defibrillation and followed by CPR for 2 minutes and epinephrine. Once the intervention is completed, reassess the rhythm. This time, the rhythm is asystole. And since it's asystole, again, you no longer need to check for the pulse and remind yourself that asystole is not shockable. Then proceed with the appropriate interventions. Again, for non-shockable arrest rhythms, the only interventions are CPR for 2 minutes and start or continue epinephrine doses every 3 to 5 minutes. Once the intervention is completed, reassess the rhythm. This time, the rhythm is sinus. You then check for a pulse, and there is a pulse. And so you will now exit the adult cardiac arrest algorithm and proceed with the bradycardia, tachycardia, or post-cardiac arrest algorithm as appropriate. Epinephrine is the most commonly used drug in cardiac arrest. You give 1 mg every 3 to 5 minutes and 2 to 2.5 mg via endotracheal route. Special precaution must be observed in patients with hypersensitivity, hyperthyroidism, and Parkinson's disease. Amiodarone is another common drug used during cardiac arrest. Administered for VFib or pulsus VTAC, it is initially given intravenously at 300 mg IV, and the second dose is given at 150 mg IV. The same doses can also be given intraosseously. Lidocaine is an alternative to amiodarone in patients in VFib or pulsus VTAC that are unresponsive to CPR, shock, or vasopressor. It is initially given as 1 to 1.5 mg per kilogram IV bolus, and the second dose is given at 0.5 to 0.75 mg per kilogram IV bolus. Defibrillation is the therapeutic use of large electrical current delivered over very brief periods of time. It temporarily stuns a quivering heart to allow a more coordinated contractile activity to resume. Defibrillation is the treatment of choice for ventricular fibrillation, which is the most frequent initial rhythm in sudden cardiac arrest. It is critical and should be administered as early as possible to improve survival. It is because the probability of its success diminishes rapidly over time, and VFib tends to deteriorate to asystole within a few minutes. CPR is done prior to defibrillation if the machine is not yet available, and resumed right after delivering the shock. CPR is important because it prolongs VFib. It delays the onset of asystole, and it extends the window of time for which defibrillation can occur. CPR actually improves the heart's response to defibrillation. This slide was first shown in the BLS and AED modules. This highlights the impact of early CPR and early defibrillation on the outcome. The survival rate increases significantly with earlier defibrillation. These are the types of defibrillators. Manual defibrillators are either monophasic and biphasic. The automated external defibrillator or AED was previously discussed. Now let me teach you how to use the defibrillator. Step 1 is to ensure scene safety for the rescuer and the victim. Step 2, remove any transdermal medications and shave chest if possible to ensure adequate skin contact with paddles. Chest hair can increase transthoracic impedance that can negatively affect the success of defibrillation. This could be reduced up to 35% by shaving chest hairs. Shaving chest hairs is recommended before delivering the shock. Step 3. Apply gel on paddles. Step 4. Turn the machine on. This picture is an old monophasic machine which is still being used in some hospitals. On the right is a newer model. The red arrows both point to the on button. Step 5. Select the energy level. For older models, you select by rotating the dial clockwise up to the energy level desired. For newer models, press the arrow up and the energy level is displayed on the screen. Step 6. Press the charge button. It takes only briefly to charge the machine, and once fully charged, this will be displayed on the screen. Usually, machines will sound off once it is fully charged. Step 7. Ensure proper placement of the paddles and electrodes on the anterior lateral positions. Step 8. Check the surroundings. Make sure everybody in the team is clear. Step 9. Press on the discharge button, which is always a red button on the paddles or on the body of the machine. Do not immediately remove the paddles off the patient's chest after pressing on the red button. Wait a second or two after the shock has been delivered before removing the paddles. The paddles must be parked back to the machine after using or when not in use. And remember that chest compressions must be resumed immediately after the paddles have been removed from the patient's chest. Let me check what you have learned so far with the case. A 40-year-old male is brought to the ER unconscious. Vital signs were 0. What should you do? A. Call for a code. B. Perform CPR. C. Hook to a cardiac monitor. Or D. All of the above. If you think A, B, and C are all correct, then you are right. Your instinct is to do CPR right away, but the other two must be simultaneously done when attending to a cardiac arrest patient. Good job! Unhooking to a cardiac monitor, you saw this rhythm. What is the next best step? A. Intubate the patient. B. Insert an IV line. C. Do chest compressions. D. Defibrillate to 360 joules. The rhythm that you saw is ventricular fibrillation. While CPR must be instituted right away because it is a pulseless rhythm, the most definitive and effective intervention is defibrillation. So if you answered D, you are right. Good job. Because of your management, he converted to this rhythm. What is this rhythm? Yes, you are right. This is sinus rhythm. You are correct. Good job. Let me give you another case. Your patient is an 80-year-old woman who is admitted to the ICU because of sepsis. She is hooked to high O2 support via face mask. You noted her to be unresponsive. The cardiac monitor is sounding and showed this. What do you do next? A. Intubate the patient. B. Give amiodarone 300 mg IV. C. Do chest compressions. D. Defibrillate to 360 joules. Airways, though important, is no longer the priority in most recent guidelines on ACLS. Amiodarone and defibrillation have no role in asystole. So if you answered chest compressions, then you are correct. Good job! Because of your management, he converted to the following rhythm. Good job! These are the key points that you must remember when dealing with cardiac arrest patients. There are 4 cardiac arrest rhythms, namely ventricular fibrillation, pulseless ventricular tachycardia, pulseless electrical activity, and asystole. Cardiac arrest quickly deteriorates if not identified and managed immediately. Defibrillation done early improves outcomes in cardiac arrest patients. Remember to resume chest compressions right after defibrillation. Epinephrine has no top dose and can be given every 3 to 5 minutes. Drugs like amiodarone or lidocaine can be given in hard-to-manage or refractory shockable rhythms. And a coordinated and efficient team approach translates to better outcomes for cardiac arrest patients. Thank you for listening. Your next module is on bradycardia.